So today I'll be talking about how I've been trying to create a new drug for pediatric medulloblastoma. So pediatric medulloblastoma, it's the most common malignant brain tumor of childhood, and actually recently brain cancer has become the leading cause of cancer-related death in kids. And it's a very aggressive tumor that has a very aggressive treatment approach. It includes surgical excision followed by irradiation of the whole spine and the brain, followed by a year of multi-drug chemotherapy. So you can imagine in a fully grown adult brain, this would be difficult. But you think of a young and developing brain and how vulnerable it is, this type of approach is frankly devastating in these children. And as a result, even those kids who do survive end up with significant neurological and cognitive morbidity as a result of the treatment. Furthermore, there are many children who undergo the rather hellish treatment paradigm and still succumb to the disease. So what I really wanted to do was create a better, more targeted approach for these kids to avoid some of these treatment-related morbidities. And the way I approached this was through the sonic hedgehog signaling pathway. So this is the hedgehog pathway. It's a series of inhibitory steps, ultimately resulting in activation of the GLI target genes. Because of its fundamental role in medulloblastoma, its dysregulation causes a quarter to a third of these tumors. A lot of work has gone into making drugs that target the hedgehog pathway, and one of these, vismodegib, has gone into children. While initially it had a very dramatic effect in terms of regression of the tumor, proving that hedgehog inhibition in itself is sufficient to cause tumor regression. Unfortunately, 3 months after stopping therapy, there was a recurrence of the tumor. And this was found to be a result of a point mutation in smoothin that rendered it resistant to the drug, but still able to signal. So entering my PhD, what I wanted to find was a new target that was downstream of smoothin. It had to be druggable. Not all proteins are equally druggable. And ideally, it would be resistant to resistance. And of course, of these three tasks, the third was by far the most daunting. But I took an approach that combined cancer biology with developmental neurobiology and new techniques in mass spectrometry, and identified casein kinase 2 as a potential target for medulloblastoma. CK2 had a lot of the attributes that we were hoping for. It acted downstream of smoothin, and in fact, it acted at several spaces downstream of smoothin, at the level of GLI, but also its interaction with target genes. And finally, it was known to be important for PI3 kinase signaling, which indirectly affects hedgehog signaling. Like most kinases, CK2 is highly druggable. And we were hoping that ideally it would be resistant to resistance in that its effect at 3 different spots in the hedgehog pathway made it very difficult for any one pathway mutation to overcome the drug. So we were quite enthusiastic, but of course, we didn't know anything at this point about whether or not it actually worked. So what we did is we took some cells, medulloblastoma cells, that had the point mutation in smoothin that rendered it resistant to vismo, and we injected into the flank of mice and let them grow. Here you can see the tumor growing over time. The control in the vismo-treated mice grew similarly thanks to that point mutation. But in contrast, our CK2 inhibitor mouse had near complete loss of growth and in fact regression in many of our tumors. If you look at the actual picture, on the top you can see where the tumor was injected and then went on to regress. In contrast, on the bottom, you can see the very large tumors in the control-treated mice. So what we finally did was sort of the ultimate study. It was a double-blinded, randomized controlled trial using these same vismo-resistant cells that we injected into the brain of the mice these times. So our blinded collaborator injected the cells, began treatment, and then recorded when the morbidities occurred. And what you can see in the control-treated mice, all mice were dead by 17 days. However, in our CK2-treated mice, about half of them continued to survive up to 100 days despite stopping treatment at day 30. And in fact, at this point, I sacrificed one mouse, and I sent it to pathology, and there was no sign of residual tumor. And the remaining mice continued to survive a year later, which is well outside of the period where we would expect recurrence to happen. So at this point, I had this drug. I was very excited. It looked like it was more promising than any drug I had seen before. But now what? And before starting with Spark, I had this preconceived notion that as a scientist, you publish your paper, and if it's great, pharma will come in and change your paper into a drug ideal for your orphan pediatric disease. It turns out that's not quite how it happens. And while I didn't have a fairy godmother, I did have Spark. And one thing I really want to highlight is the effect of Spark this early in my career path and in this project's path. When I think of, as an MD, the valley of death, going from the preclinical studies to patients, I thought of it as a very overwhelming type objective that's really in the realm of pharmaceutical companies. And what Spark did is it took this very almost impossible objective and instead broke it down to a series of challenging but achievable steps. The first of which was deciding whether I wanted to come up with my own drug or go with the one CK2 inhibitor that had been tried in phase 1 trials in adults. With a lot of advice from Steve, actually, we were able to narrow in on the fact that the clinically optimized drug was, in fact, gave a more robust and a more enduring effect. So for that reason, we went towards the CX-4945 approach. Here we had 4 major tasks ahead of us. The first was to approach a pediatric brain tumor consortium who would actually help run the trial. And in fact, here this wasn't that challenging. We had a great deal of enthusiasm from Dr. Mariam Fouladi and Dr. Ralph Saloom. And Mariam at the time was the head of the PBTC. Next, we had to find some type of IP landscape and consider how we were going to actually approach developing this drug. And here I'll say I had advice from very many of the Spark advisors. We had several routes going forward and support from OTL through Greg Kyle and Kyle Gurley. Our last task was the most daunting, and that was approaching Senwa, who owned the drug. And I guess when I heard today this idea of the begging stage, this was certainly where we approached the begging stage of the project. But with the support of Spark and the PBTC, we had hundreds of email exchanged, multiple calls. We recruited Paul Fisher from here at Stanford, and Kevin went so far as to get on a plane, organize a face-to-face, and fly down with me to talk to Senwa. And with that, we got their attention finally and brought them to the table. And here I'd like to highlight the second really major impact of Spark on my approach. And that's, I think, very few people would have a lot of confidence in the ability of a single graduate student to cross this valley of death. But what Spark did was surround me by this amazing group of people, frankly, world leaders in pediatric brain tumor development and drug development. And I think while few people would have confidence in just me, there's a lot of people who would support this group of people and their ability to make a drug that gets to children. And luckily for us, one of the people who supported it was the CEO of Senwa, who agreed to provide drug for a trial in early April. Later that month, the PBTC agreed to run the trial for us. In June, we filed our provisional patent. And just now, we're submitting our LOI to the FDA. Going forward, we're on a fairly rigorous timeline that sets us up to get drug to child as of next fall. So with that, I'd like to thank everyone at Spark. It's been really a tremendous privilege to be part of this program, especially Kevin and Daria and Steve, who's been an instrumental mentor throughout the process. Thank you very much. I think in general, a lot of companies are resistant to enter the pediatric world, just because it is an orphan disease. There's not a lot of financial incentive to go into children. Recently, that's changed a bit with the Creating Hope voucher. But I think also they get really nervous because the toxicity in a child could easily derail their adult ambitions. So in general, I think it's especially a smaller company like Senwa, which pretty much has this compound and one other. They're really worried about risking it in a pediatric population, and risking it in collaboration with academia, which doesn't always go at the same pace that you do in industry. So I think there was a lot of reasons why they would not agree, and I was really, I think a lot of people were convinced that they wouldn't agree, and I think it's partially a nod to Senwa itself in that their ultimate decision was in part the Creating Hope voucher and the financial incentive associated with that, but also that their company seems genuinely interested in helping children and getting this drug to children. And in fact, they've even offered to make a pediatric elixir formulation for us so the kids don't have to swallow the pills. So I think we were lucky in that they seemed really enthusiastic to help us in the end.
Offer another round of applause for...
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.